Before we get started, I need to get something important out of the way. Happy opening day week to all who celebrate America's favorite pastime. That's right, baby. Baseball is back. Go Stros, go. Now that that's out of the way, I can hear some of y'all thinking I am obsessed with mechanical compression devices, or MCDs. I can even understand why y'all may think that. I've never done a series of podcasts on a single topic before, and this will be the fifth one on this topic. In episode 92, we talked about MCDs and in-hospital arrest and a study that showed worse outcomes with MCDs. Then in episode 93, we talked about how Austin had extensively trained on how to appropriately apply the Lucas device so that they would minimize application times, and survival still dropped. And then in episode 94, we moved on to two large randomized control trials and a well-done observational study in Richmond, Virginia, that all used the autopulse. Two of those studies showed no difference, and one RCT actually showed worse survival to discharge. Now, I might have voiced some opinions on the concept of goalpost moving. That is, where initially the sponsor says our aim is to show superiority, but then in the face of negative evidence, they change their objective to talk about equivalence. I might have even given the opinion that I thought that was bad. Now, in episode 95, we turned our attention to the Lucas device, and we talked about the Link and paramedic trials that showed no benefit with mechanical compressions, and in one of them, worse outcomes in patients with an initial shockable rhythm. Now, if y'all are feeling tired of hearing about MCDs, trust me on this, I am just as tired about talking about them. But I get a lot of questions about these things when I'm talking at conferences, and I am very well aware of the general consensus that they save lives despite all of the evidence, that they don't save lives. You might say, I wanted to get these episodes off my chest because what is the point of having a podcast about clinical literature if you can't share what the literature says about clinical things? So, because of that, I'm going to wrap this episode up so I can move on to all the other cool papers that are out there. Now, we're going to start with a Utah registry study, and then we're going to move over to Vienna, Austria for another observational study, and then up to Anchorage, Alaska for a QI paper, and we're going to wrap things up in Cincinnati. And then I'm finally going to get around to giving y'all my overall take on what we should do with these things. So stick around and we'll get right into it.
Welcome to the EMS Lighthouse Project podcast, illuminating the darkness of current EMS clinical practice with the bright light of science. Here's your host, Dr. Jeff Jarvis.
Howdy, y'all. I'm Dr. Jeff Jarvis. Welcome back to another episode of the EMS Lighthouse Project podcast, where we shine the bright light of science on the darkness of current EMS clinical practice. So let's jump right in. We're going to start off in Utah with a paper by Dr. Scott Youngquist and colleagues titled Mechanical Chest Compression Devices Are Associated with Poor Neurological Survival in a Statewide Registry, a Propensity Score Analysis. And this paper was published in Resuscitation in 2016. Now, it turns out Utah is a CARES state, meaning they use the CARES registry, cardiac arrest registry, to enhance survival. And they enter all of their hospital arrest into that registry along with follow-up data from hospitals. Now, it seems like they do this in a pretty cool way. The state hired a CARES coordinator who does the entry based upon EPCRs that are submitted to their state registry, and then that coordinator gets the follow-up information from the hospital. That's a bit different than other places, and it's definitely different than what happens in Texas. In Texas, each individual EMS agency and each individual hospital enter their data in. Now, I like the Utah approach, even though I know Texas and New York and Florida, California are too damn big to have one central location doing all that, but I like the concept anyway. And the reason I like it is I think it allows for better consistency in using data definitions, and that likely results in better reliability. So Dr. Youngquist and his colleagues looked at all adult non-traumatic cardiac arrest patients from 2012 to 2015. They broke patients up into two groups based on whether they had any MCD use or not. Now, because MCD use wasn't randomized, they used propensity score matching and regression to control for confounding differences between the two groups, things like age and etiology of the arrest, initial rhythm, the usual things. Now, they had two outcomes: overall neurologically intact survival from any initial rhythm, and then neurologically intact survival from Utstein cases. Those are the witnessed ones with a shockable rhythm. Now, the reason we measure Utstein survival is because these are the patients that a good EMS system is most likely to save. Now, they ended up with just over 2,500 arrests in the data set, and 92% of these, at least of the MCD used, those were Lucas devices. There were 405 patients treated with mechanical CPR and 2,100 patients with manual. Functional survival, meaning those discharged with a CPC score of 1 or 2, that was 4% in the mechanical group and 11% in the manual. Functional survival among Utstein cases was 18% in the mechanical and 36% in the manual. Both of these outcomes were statistically significant. Now, their statistical model comparing mechanical to manual compressions for overall functional survival showed an adjusted odds ratio of 0.56 with a 95% confidence interval from 0.34 to 0.94. That is both clinically and statistically significant and represents 44% lower odds of neurologically intact survival using mechanical compressions. Now, the next paper I want to hit is from Vienna, Austria. It is by Dr. Zeiner and colleagues, and it's titled "Mechanical Chest Compression Does Not Seem to Improve Outcome After Out-of-Hospital Cardiac Arrest, a Single Center Observational Trial." You gotta love a title that just gives you the answer right up front. MCDs do not seem to improve outcome. Well, there you have it. It was published in 2015 in Resuscitation, and as the title implies, single center observational trial from the Vienna, Austria EMS system. Now, Vienna is a city of around 2 million people, so we're not exactly talking about a small system. It sounds like they have a combination of an American-style ambulance system where EMTs and paramedics respond in ambulances, and then they tack on a physician-staffed fly car augmentation. The study looked at all adult out-of-hospital cardiac arrest patients in 2013 and 2014, and they compared the ones that were treated with MCDs to the ones that were treated with only manual CPR. Now, they used a Cox regression hazard analysis. That's basically a type of regression that looks at mortality at different points in time. So why the hell did they do that? Well, because they got to deal with resuscitation bias. So resuscitation bias is where patients who are still in arrest for long enough to get an MCD applied, well, those are likely to have a worse outcome than those who get ROSC after, say, one defibrillation and before you can get an MCD on. Now, they also adjusted for all of the other usual confounders: age, shockable rhythm, all of those things. Their primary outcome, survival to discharge, and a secondary outcome was functional neurologic survival among survivors. Now, it may seem like cherry picking to only look at CPC scores among survivors, throwing out all of those who didn't survive at all, but I disagree. We get overall survival in the primary outcome, but we get to look at what patients seem to care most about. If you do surveys of what patients care about, they will tell you that they would rather die than survive pegged, trached in a perpetual vegetative state in a nursing home. So that's the reason I think this outcome functional survival among survivors is useful. Now, they found 283 patients in the mechanical group and 655 in the manual group. 86% of patients who got an MCD got a Lucas. Now, survival to discharge was 12.7% in the mechanical and 17.8% in the manual. Among those who survived to 30 days, neurologically intact survival, 56.8% in the mechanical group and 78.6% in the manual. Now, their statistical model that was looking at in-hospital mortality, and remember, mortality is those who did not survive. It's the opposite of survival. That showed an adjusted hazards ratio, which we can interpret basically like an odds ratio, an adjusted hazards ratio of 1.38 with a confidence interval from 1.04 to 1.84. That means there was a 38% higher risk of death with mechanical CPR compared to manual. So what could be causing this decrease in survival with MCDs? Now, there are a couple of commonly discussed reasons, but just to be clear, it could just as easily be something else we don't know about yet. Something else entirely. But here are the three reasons that I can think of. Number one, prolonged pauses during device application. Number two, migration of the device, meaning where the plunger is plunging. And number three is prolonged compression cycles. Now, lots of agencies have identified prolonged pauses, and they've developed these approaches to device application to minimize these pauses. Dr. Mike Levy up in Anchorage and the folks at the Anchorage Fire Department, they published a great QI paper that describes how they approached minimizing these pauses. The title of their paper is A Quality Improvement Initiative to Optimize the Use of Mechanical Compression Devices Within a High-Performance CPR Approach to Out-of-Hospital Cardiac Arrest Resuscitation, and it was published in Resuscitation in 2015. They identified prolonged pauses during application in 2012. They implemented an intervention, and then they measured the differences. That intervention, it was composed of four things. Number one is training that reviewed the rationale for high-performance CPR, minimizing pauses, and it reviewed their own performance using their CodeStat monitor files. Number two is they changed their protocol to delay implementation of the Lucas until 2 cycles of CPR, about 4 to 5 minutes into the arrest. Before then, their instructions were to get the Lucas on as soon as possible. The third thing they did is they adopted a standardized 2-step application process that involved putting the backplate during one pause and then resuming manual CPR with the A-frame part of the device placed during the next scheduled pause. One leg of the device was attached and manual compressions were resumed. Then the second leg was placed over the arms of the manual compressor until it was locked in place. And then the piston was extended and the device was started. Number four is immediate resumption. They trained hard on immediately resuming manual compressions anytime the device malfunctions or hiccups or does anything else, rather than what they were seeing, which was they would just hold off on manual compressions until they could troubleshoot the problem. So, those four things. Now, the paper, by the way, does a really nice job describing each of those steps, particularly the application process, about how they did that two-phased process. So they include a really cool picture in the paper, and I'm including that in the YouTube video, so you don't have to hunt it down. Now, their main thing they were looking at is those pauses and decreasing the duration of the pauses. They found that by implementing these 4 steps, they were able to decrease their application process from slightly under 20 seconds before to under 10 seconds after. And they also saw their compression fraction, the proportion of time they need to be doing CPR that they are, increase from 90% to 95%. Now, because this was a QI paper, they reported on their aim of improving application and minimizing pauses, but they didn't report outcomes. It stands to reason, however, that this improvement in application time should improve survival. But it turns out that wasn't the experience in Vienna or in Austria, where they carefully implemented similar strategies, and lower application times actually ended up with lower survival. To be clear, we should not read into this that shorter application times lower survival. That would be clearly a bad take and just downright silly. But it likely does indicate that even with optimal application, survival still doesn't improve. In other words, optimal application is necessary but not sufficient. Now, the second potential cause for lower survival is migration of where the compressions are occurring. We've certainly seen this in Fort Worth, but others have identified it as well. We call it MCD walk because the piston walks around the chest. And to be clear, this migration is not specific to mechanical compression devices. We certainly see it with manual CPR too. There was even a small feasibility study trying to show that you could do transesophageal echocardiography, meaning dropping an ultrasound probe down an OG tube and placing it right underneath the heart so you can really identify what's getting squished and what's not. And what that feasibility study showed is that even with manual CPR, the area of maximal compression was over the left ventricular outflow tract in more than half of cases. As it turns out, compressing over that outflow tract actually decreases output instead of increasing it. We saw compressions migrating south in our QI efforts in Fort Worth. Inferior migration can, and should, by the way, can be mitigated by using the neck strap supplied with the Lucas, and that's the reason they put that in the instructions. And we ought to do that even if the patient is not being moved. The reason for this is the device can move all on its own, even if you're not moving the patient. So make sure to use the neck strap as soon as you apply it. In Williamson County, when I was there, they also identified this migration. The commanders who had the Lucas with them noticed it was moving around, and they just grabbed a Sharpie and stuck it to the neck, stuck it not to the neck strap. They made sure to use the neck strap, but they stuck the Sharpie to the arm of the Lucas device. And then they would draw on the chest once the piston was appropriately placed and getting maximal compressions. How did they find maximal compressions? Well, they put it where they thought the right place was, and then they looked at the end-tidal CO2. If it was low, they moved it around a little bit until it came up, and then they marked and said, that's the spot. That allowed them to identify when the device was moving. Now, the third and final reason I can come up with for MCDs either not improving survival or actually lowering it is because prolonged periods of compressions without pausing for rhythm checks. In Fort Worth, we call this marathon CPR. Why? Well, because the folks that I work with in OMD are very creative when it comes to naming things. Now, marathon CPR can potentially decrease survival because VFib needs to be recognized before we zap it. If we're not pausing compressions to analyze the rhythm, we're probably not seeing CPR, and we're probably not seeing VF, and then we're not shocking it. So those things are kind of bad. Now, the folks with the Cincinnati, I have no idea where Cincinnati is. The folks in Cincinnati, however, they described this concept of marathon CPR in a 2023 paper. The title of the paper is Lucas Device Use is Associated with Prolonged Pauses During Application. Yep, got that, seen that a lot. And long chest compression intervals. It was published in PEC in 2023 by Drs. Morgan, McMullen, and their colleagues in Cincinnati. They analyzed their arrest using the CodeStat analysis package that comes with their life packs. Now, when looking at these things, it really becomes obvious when compressions are manual and when they're mechanical. And from these, they could see clear periods where compressions went for minutes and minutes without pausing to check rhythms. Now, they include a sample in their paper where one cycle went on for over 5 minutes without interruption. So they calculated the median pause during application and found that it was 22 seconds. And they compared that to other interventions that could lead to prolonged pauses. They looked at airway management. They looked at defibrillation. They looked at no procedures at all, just pauses. And what they found, all of those were associated with pauses of under 10 seconds. So MCD application was clearly the leading cause of prolonged pauses. Now, they also measured the duration of compression cycles without pauses for rhythm analysis, and they compared these links to CPR cycles both with and without the Lucas in place. The median duration of cycles was 38 seconds in the manual CPR group. 38, yeah, that seems kind of short to me. But they found 133 seconds with the device. All right, so the pauses are longer when you're putting the device on than when you're not. Now, 40% of those segments, and by segments they mean CPR plus the pause, 40% of those segments with the Lucas were less than 3 minutes long, while 94% without the Lucas were less than 3 minutes long. Now, in the segments with the Lucas, they found 32% were between 3 and 4 minutes, another 17% were between 4 and 5 minutes, and 11% were longer than 5 minutes. So almost 60% of all compression cycles with the Lucas in place were longer than 3 minutes. And remember, the recommendation is 2 minutes before rhythm. Now, in the no Lucas segment, 6% were between 3 and 4 minutes, and none of them were longer than 4 minutes. Now, there are definitely more papers, including several systematic reviews and meta-analyses, and they all show the same thing. Mechanical compression devices, as currently built and as currently used, do not improve survival. And there is substantial observational evidence that they might actually lower survival in the real world. Now, I'm going to spare you, and me for that matter, I'm going to spare you from reviewing any more of these papers, and I'm going to leave you with my final take on MCDs. Now, to be clear, what I've talked about up to this point is what the evidence shows. So now I'm going to switch from that evidence to just my opinion, man. I'm going to tell you how I interpret this evidence and how I put it into practice. So first off, I see no evidence anywhere, even when used correctly, that MCDs improve survival. Minimizing pauses during application is not enough to improve survival. And marathon, CPR, and MCD walk or migration, those are real things. But I'm not convinced that even minimizing those are enough to improve survival. Certainly, there hasn't been any evidence yet that anyone has gotten it all right and seen better survival. Better survival that you can attribute to the device. So, MCDs don't improve patient survival, but they very well may, however, improve our survival. Now, we know that the odds of collision when transporting patients to the hospital increases by 158% when using lights and sirens. And I'm pretty sure if we're transporting cardiac arrest with CPR in progress, we're probably going to be using lights and sirens. That 158% increase in the risk of collision, that's from the Watanabe and Brown paper, and they looked at this using NEMSIS data, millions and millions of calls. Now, we also know that it is almost impossible. Now, hell, I'm going to go out on a limb and say it is absolutely impossible to do manual CPR, regardless of whether the CPR is good or not. You just can't do it while you're safely seatbelted into the back of a truck. We know transporting CPR in progress is just more dangerous. Now, while I care deeply about improving survival from our patients, I care even more about the survival of my colleagues. If we haven't achieved ROSC on scene, we are unlikely to achieve it en route, regardless of the quality of CPR. So I am very clear here, at least in my opinion, I am very clear that the benefits of MCD in allowing us to safely seatbelt in if we have to transport CPR in progress, that easily justifies their use for transport alone. So I want to be clear, I am not saying we shouldn't use mechanical CPR. And I'm going to say that again for the record, despite any evidence saying it may be hurting survival, I still think we ought to use them. In other words, I don't think the proper question about MCDs is if we should use them. Instead, I think it is when we should use them. Now, several papers tell us what we intuitively know. Most patients who survive cardiac arrest get ROSC early in the resuscitation. The longer they're in arrest, the lower the odds of their survival. And early on in an arrest, doing the simple things, simple but hard, the simple things that we have discussed on multiple episodes of this podcast, that is what improves survival. Early and high quality CPR, early defibrillation, including dual sequence, early epinephrine, and I can't believe I'm saying good things about epinephrine, early epinephrine, at least the first dose. Anything after that, Lord only knows. Maybe even early bicarb and unwitnessed non-shockable rhythms. And anything that interferes with these things is almost certainly going to decrease survival. And unfortunately, the evidence suggests MCDs interfere with these things. But the longer a resuscitation goes on, the more difficult manual CPR becomes. Even with lots of young, healthy, fit clinicians, good quality CPR is hard to maintain for very long. Lord knows I'm 57 years old. I certainly can't do great CPR for very long. And when I do, I can't walk straight for a couple of days after that. Now, yes, that probably says more about me and my fat ass than it does about CPR, and it might suggest I need to get to the gym a little bit more often. But still, good CPR is hard. We can do it, but not for very long, no matter how many people we have there. And as the salespeople say, that machine ain't going to get tired. So overall, I think that over time, the benefits of high quality CPR and focused interventions, it diminishes and the advantages of mechanical CPR increase. The big question, of course, is at what point does this happen? When does it make sense to switch to mechanical CPR using all the proper techniques that we've talked about? My evidence-based answer, meaning the one that the papers tell me, that answer is I have no idea. There have been no studies about this that really help us. There was, however, a nice study looking at the similar concept, the similar question of when the benefits of on-scene resuscitation are exceeded by the potential benefits of early transport for eCPR. Doctors Granal, Cheskis, and their colleagues estimated 16 minutes was the right balance to answer the question of when is the best time to consider transport to the hospital for eCPR. That paper was published, by the way, in PEC in 2016. Now, 16 minutes seems like a reasonable period of time, and I think we can extrapolate on when it is time to move from high-performance CPR, maximizing all of the good things on scene, to transport for eCPR. I think we can extrapolate from that to when does it make sense to implement mechanical CPR. 16 minutes? Sure, why not? Now, I picked 15 minutes of maximized manual compressions, early interventions, and effective ventilations. I felt like that was the right time to move to MCDs. Is it the right time? Again, I have no idea. But after reading and thinking an awful lot about this, it seems like that's the best balance, and it's what we're going with in Fort Worth. Now, I know people feel very passionately about MCDs. Most of the online EMS forum conversations I've come across about MCDs, they are heavy on passion and short on evidence. It turns out there's this frustrating phenomenon called blowback. It's where people who have a passionate belief about something, whatever the something is, they're not very likely to be swayed by evidence. And as a matter of fact, when they get dug in, showing them more evidence makes them more dug in. Again, that's called the blowback phenomenon. It's very frustrating. But one other thing that we're seeing in psychology is that you can immunize people against this. And you see this when it comes to misinformation about all manner of things. Vaccines, not that, we have a no vaccinating against measles problem in Texas or anything. But it seems like you can vaccinate, if you will, against information that goes against the literature by telling people about what the evidence says up front before they get exposed and develop those passionate beliefs. Now, the blowback thing about where you get more dug in, the more evidence you get, I don't understand how that works, but I do acknowledge that it does work. I acknowledge that it exists. So even if I can't combat that, at a minimum, I want to at least try to inject what the evidence actually says into the conversation, perhaps immunizing people against false beliefs that go against the evidence. Now, if we are at a bare minimum aware of the evidence, we might be able to work to make the devices better, maybe improve how we use them. I saw a paper that was showing, it was just animal labs, but it was showing a device that could migrate itself around in a position to optimize circulation. Maybe that's what we need to be doing. But we're never going to recognize the need to study that if we get dug in and say they already save lives. The goal here really needs to be to improve outcomes, not simply support or detract from a specific device. Why? Well, because after all, it's about our patients, not our arguments. Guys, thank y'all for indulging me over the last 5 episodes as I got this off of my chest. I promise the next episode will have nothing at all to do with mechanical CPR. Don't know what it will be about yet, but I'm going to go find a cool paper having nothing to do with MCDs. Thanks for listening, and as always, thank you for what you do every shift to take care of your communities. Take care, y'all.
You've been listening to the EMS Lighthouse Project podcast, a proud member of the FlightBridge Ed podcast family and a Fire Dog production. Visit flightbridgeed.com for more information.